Thank you, Kathy. Thank you, everybody, for being here and coming out to hear this talk today. As Kathy said, I hail from Boston. I work at Mass General Hospital in Boston. I'm also, in addition to what Kathy mentioned, including a very proud member just recently of the Advisory Council for ThyCa, involved in the International Thyroid Oncology Group as well. That's both ThyCa and ITOG are organizations that are near and dear to my heart, so it's especially nice to be here today. And I will mention ITOG a couple of times, and I've also brought the recent newsletter from ITOG, and I left it in the back on a table, so please pick one up on your way out and check us out. So I have to apologize in advance. I do have to make it to the airport on time to catch an early flight. So I do plan to finish up by 10:45, and I won't be able to stay late to talk afterwards. So you have free license to interrupt me and ask all of your questions at any point along the way, and I'm very happy to answer any questions that you might have, and hopefully this will be as interactive as possible. So I'm going to be talking about new drugs for iodine-refractory differentiated thyroid carcinoma, and hopefully get at some of the things that we wrestle with in clinic when thinking about the patients and how we can best try to tackle their disease. So I'm going to dive right in. I'm speaking to an audience who probably knows this disease very well, but most people with differentiated thyroid carcinoma will do quite well. Most patients will be cured of their disease with surgery, perhaps plus or minus radioactive iodine. But unfortunately, about 10 or 15% of patients with differentiated thyroid carcinoma won't be cured of their disease, and those patients in general have a tough time, which can last over many years. There can be many therapies involved, many surgeries, many courses of radioactive iodine, and now other drugs as well. So I'm going to be talking about the other drugs. But first, I think it's important to recognize that this is not a one-size-fits-all disease. People with metastatic differentiated thyroid carcinoma or recurrent disease that's in the neck that's unresectable do still have a variable course of illness. Some people do very well over a long period of time. Other people have very rapidly progressive disease. So when we think about the survival of this patient population, you can see here that people who respond to radioactive iodine, take it up and their cancers get smaller, survive for a long period of time. But in these curves down here, curves 2 and 3, those people who get radioactive iodine and don't have their disease shrink up nicely don't do quite as well. And in fact, their 10-year overall survival rate is only 10%. So that's the patient population that I really focus on the most. And that's the patient population that I'm going to be talking about today. So these are the things that I talk about with my patients in clinic, and these are the things that we think about when thinking about what kind of therapy do we need to consider and when do we need to consider starting therapy. So one of the most important things is to try to get a handle on what the disease is like. How aggressive is it? Is this a patient who is going to be fine if I have them come back a year from now and have a CT scan at that point in time and nothing else in between now and then? Or is this somebody whose disease is going to be growing month by month over the next several months, and I need to see them in 2 months' time rather than a year's time to really get a handle on their disease? And so how do we figure that out? So partly it's, what's happened before they've gotten to me. So whether somebody's had a very large cancer at the initial diagnosis, how the original surgery went, whether they've had radioactive iodine in the past and what the response was. We need to think about those things. I also think about what the histologic subtype is. So, of course, there's papillary thyroid carcinoma, follicular thyroid carcinoma, but there are also other variants of these cancers. For example, the tall cell variant of papillary thyroid carcinoma tends to do slightly worse than the classical variant papillary thyroid carcinoma. So I really like to know that. And many people who come from outside institutions with their pathology reports don't have a pathology report that describes the subtype of the cancer, what it really looks like underneath the microscope to a good endocrine pathologist. So I always have my patients' cancers be reviewed by our really good endocrine pathologists. I'm really lucky to have those guys right in the next door building from me. And they can help give me an idea of, is this a classical variant? Is it tall cell? Is it a poorly differentiated thyroid carcinoma? Is it an anaplastic thyroid carcinoma as well? It's also important to think about how much disease is there. Is there a lot of cancer? Is there a little bit of cancer? And that really makes a big difference. I mentioned how quickly is the disease growing. And on the initial visit, lots of times we don't know that. If somebody has had one chest CT scan in their lives that shows several small lung nodules, you have no idea how long those lung nodules have been there and how big were they a year ago. So often we have to do regrouping 2 months, 3 months from that initial CT scan to really know how quickly things are progressing. It's, of course, important to know if there are any symptoms. I think it's fair to say that somebody who has iodine-refractory differentiated thyroid carcinoma who has symptoms from their disease pretty much is going to need to have some treatment to at least get those symptoms better. So that's a critical thing that we definitely don't want to miss. But we also don't want to miss somebody who's going to be who has impending symptoms. There can be disease in a particularly bad area that's not very large, but's in sort of a pricey environment, like in the neck, close to the trachea, or close to the larynx, or close to the esophagus, that could affect breathing or voice or swallowing. And if something is small but growing rapidly in a pricey area, we're going to want to do something about that sooner rather than later. Of course, we need to think about what the treatment options are, and I'll talk about that a bit. How well does the treatment work? And what are the limitations of treatment? So if we had a perfect treatment that didn't cause any side effects and cured everybody, then this column on my right-hand side wouldn't matter at all. We would just give it to everybody. But unfortunately, the treatments that we have don't cure cancers in most circumstances when we're talking about metastatic iodine-refractory disease. They do work, but they don't work forever, and they cause side effects. So we have to think about all of those things. Yes?
A quick question, but it flies in the face of what we hear is that most of the patients with papillary thyroid cancer do extraordinarily well, and your initial slide said 10 to 15% develop metastases. Was this a slide of all comers or strictly papillary?
So that's a great question, and let me just rephrase the question for the... Yeah, so, let me go back to that slide. So the question is we hear that papillary thyroid carcinoma does quite well, and this slide, and I seem to be saying something that's otherwise. And does papillary thyroid carcinoma fall into this percentage of patients who have a 10-year overall survival of 10%? And the answer to the question is yes, there are people with papillary thyroid carcinoma that is metastatic, recurrent, iodine refractory that will fall into the patient population that does have a relatively poor overall survival. However, these are statistics based on large groups of patients, 100 patients or 1,000 patients. So when we talk about the median survival of a group of patients, what that means is that if you take all comers, the statistical median will be whatever, say it's 7 years. But then there will be people who unfortunately won't even do that well, who won't survive that long. And then there will be other people who will survive much longer than that. So there can be plenty of people with papillary thyroid carcinoma that's iodine refractory who will live well beyond 10 years' time, but unfortunately that's not the case for everyone. So thanks for asking the question, and thank you for being the first person to ask a question. Now everybody else has to do the same. So just to talk a little bit more about the nature of the disease. So these are the things that we think about. When thinking about the rate of progression, traditionally in the clinical trials that we've been doing for the last few years, we think in particular about the rate of progression over the last year. So when people have disease that's growing very slowly over a several year period of time, in general we think that their cancer is indolent enough that we might not need to start drugs with side effects right away. But if the disease is growing within a 12-month period of time, or say 13 or 14-month period of time, those patients in general have been eligible for the clinical trials that we've been doing recently. And we define that rate of progression by what's called the RECIST criteria. RECIST stands for Response Evaluation Criteria in Solid Tumors. And the definition of progressive disease by RECIST is that you take the sum of the longest diameters of the lesions that you can see, like on a CT scan or MRI, and then you compare that to the prior CT scan, so that if there's an increase in the sum of the longest diameters or the tumor measurements by 20% or more, that meets the definition for progressive disease. Now, that might not be clinically meaningful, but that's one of the eligibility criteria that we've been thinking about for clinical trials in the last few years. Yes?
So is the prior CAT scan 6 months, a year? I mean, when you're measuring this 20%, what's the previous time frame?
So the question is when looking at the RECIST criteria, what time frame is used? And we deal with reality and whatever the patient's, whatever the time frame is from the patient's last CT scan, that's what we look at. So some people who have had slowly progressive disease or slowly growing disease may have a CT scan once a year, and so that's the available time frame for comparison. Some people may have CT scans every 3 months or 6 months, and so we look at those. One thing, though, that's important to do and doesn't necessarily come with the formula that's provided by our radiologists when they give us the radiology report is not just what happens compared to the last CT scan, but what's happened compared to the one before that and the one before that. Often the radiologist will say, oh, we had a CT scan today and we had one 3 months ago, and their report will tell you what's changed over those last 3 months, but they don't say anything about what today's CT scan is like compared to the CT scan that was available a year ago. So I always look at these myself, and sometimes I need to go over them with the radiologist as well, but I want to know what's happened over time, and is there been a big change? Is there really no change between now and 3 months ago, but was there a more obvious and more dramatic change between now and a year ago? And sometimes looking back farther gives you a different feel for exactly how quickly things are growing.
Can I ask another question?
Of course.
So what if you see the rate of growth over a period of time slowly, but it still exceeds the 20%?
So the question is what if the rate of growth is slowing over time, but it still exceeds the 20%? That's a factor to take into consideration. There's no one factor, I think, that determines whether somebody has to start on therapy or not. You really have to take into consideration all of the factors, who the patient is, what their comorbid illnesses are, what's happening with their disease, not just is it growing by 20% or more. 21% really probably isn't too much different than 19% in reality. So you really have to look at the global picture. Yep. So of course, as I've said, not only is there the rate of progression, but there's how much disease is there. If somebody has a CT scan, so you guys have probably seen CT scans before. This is a CT scan that shows the liver. This is the liver here, and this is the spleen here. This is the patient's abdomen in the front, and this is their back. And you can see here that there are multiple lesions in the liver. None of them are really huge, but there are a number. There's one there, one there, one there, one there, one there, one there, and one there. That's a lot to me. That makes me a little bit more nervous than if the CT scan just showed maybe one liver lesion that size there and maybe one liver lesion someplace else. Another CT scan that would make me nervous is this CT scan of the lungs. So this is a slice going across about here. You can see the right side of the lung here, the left side of the lung here. A lot of these little markings are blood vessels, but they're never this many dots. And all of these many of these tiny little dots are going to be tiny little metastases. And somebody like this may begin to have shortness of breath in the not too distant future, whereas it would be very different if somebody had several of these small lung lesions, but not nearly this innumerable amount of lung lesions. So the burden of disease is very important to consider. Symptoms I mentioned. And then is the patient sick in lots of other ways, or are they really quite well? We have to think about that. And then the other thing that sometimes presentations like mine forget to mention, but we always need to think about, of course, is what makes sense for the individual patient that we're talking about. Some people, for example, I have a patient who's a dentist, and the idea of having hand-foot syndrome so that he wouldn't be able to do work with his hands, do his work as a dentist, is exceedingly important. So a side effect like that could be a non-starter for him if his disease is rather indolent and we have some wiggle room about whether we should start something now or not. Another patient might, for example, just really not be able to live with the idea of not doing something about their disease. And if their disease is otherwise justifies treatment, that treatment a little bit earlier for that particular person might make sense compared to somebody else who really has no tolerance for any side effects from therapy in general and really doesn't want to take something that's going to make them feel a little bit sick. So we really have to think about not just what the objective facts are in the case, but what this particular patient needs and how this particular patient is going to, how treatment may or may not fit into that person's life now or in the future. So just another couple of examples. So these are CT scans from patients of mine. This is a patient who had metastatic papillary thyroid carcinoma, had on CT scan multiple small nodules, not too many of them, but still there were more than just a couple. But the patient had a large pleural effusion or fluid collecting between the lining of the chest wall and the lung, pushing the lung in, and you can see that on the CT scan down here. This white area here is all fluid, and associated with this fluid collection was a cough that the patient had and shortness of breath. So to me, this patient needs treatment. This is kind of a no-brainer. There's a fair a burden of disease, and this particular patient was symptomatic, so we needed to try to fix him as much as possible. These are CT scans from another patient of mine who has metastatic Hürthle cell carcinoma. She has small lung nodules. No other disease in the bones or liver, for example, or in the neck. And her disease is fairly slowly progressive over a couple of years' time. However, she's one of those people who is really uncomfortable not doing something about her disease. So we've had many long conversations about, does she really need treatment now, or are we better waiting for her until there's more disease? So those are just two examples of the things that we think about all of the time. So I've already talked about this. Shouldn't everybody with iodine-refractory, recurrent, or metastatic DTC get treatment now beyond the TSH suppression that you all know is really an important part of the treatment on an ongoing basis, as long as it's tolerated. So, of course, the problem is that treatment really, unfortunately, in this day and age, we haven't figured it out well enough so that the treatments are potentially curative for the most part. So if we could cure someone's cancer and we could give them drugs for, say, 6 months that might make them feel somewhat sick for that time, but we had a good chance of cure after that 6-month period, it might be worth it for a lot of people to put up with those side effects for that length of time if there was a good shot at being cured. But most of our cancer treatments right now are just, unfortunately, not quite that good yet. I think we're going to be getting there, though. So I think another important question is, does treatment prolong life? Are people going to live longer if they're on effective therapy? And I think that we are getting there now, and so that's an important thing to think about. And then if treatments are going to prolong life, or are we going to have an improved progression-free survival, do we have to start the treatment immediately in order to enjoy that benefit, or can somebody wait a while and go about leading their normal busy lives and start therapy 6 months from now or a year from now, and will they still have that survival benefit? And of course, the second problem is that the treatments that we're talking about do cause side effects. And I think that it's fair to say that almost all of my patients do have at least some side effects from the therapy. We try to treat them as best we can and use lots of supportive measures, use dose adjustments when we need to. But unfortunately, it's not a free ride, certainly for the majority of patients. And for some people, these side effects really can impact on quality of life. And so that is certainly something that's very important to take into consideration. So now thinking about the individual options that we have to think about, what about old-fashioned IV chemotherapy? Basically, these are just a list of studies that have been done. As you can see here, these studies have small numbers of patients in the studies, and when you look at the response rates overall, the response rates really are pretty unimpressive and pretty modest. So basically, we don't think that this kind of cytotoxic chemotherapy really works in advanced thyroid cancer, and it's uncommon that we think about cytotoxic chemotherapy for iodine-refractory DTC at this point. The response rates are pretty impressive. They don't last very long. Survival is rather poor, and when the studies have taken a look at the survival here, and the drugs, just these kinds of drugs, we haven't seen a lot of progress over a long period of time. Yes. Right, exactly. These are the old-fashioned IV chemotherapy drugs like adriamycin that's used to treat breast cancer, for example. I'm sorry, the question was, I'm not talking about the tyrosine kinase inhibitors with this. I'm sorry, there was a question here, and then I'll get you.
It's not right on this topic, but a lot of us have problems swallowing, even regular Synthroid or whatever. And when you're approaching having to take the kinase inhibitors or whatever in pill form, it's daunting. Is there any research or any work being done so that so we're able to take it without saying, well, I just can't take it, so I'm just going to just let it go? This is what I'm feeling.
Right, so that's an excellent question. So the question is if we're talking about oral drugs like the oral tyrosine kinase inhibitors, many people with thyroid cancer have swallowing problems. So even taking a small pill like Synthroid can be difficult. The oral tyrosine kinase inhibitors are larger pills, and so the idea of taking those pills orally on a daily basis can be daunting. And is what's being done in that regard? So initially in new drug development, the pharmaceutical companies don't really want to take a look at alternatives to the standard dosing that they're doing. And it's just, for practical reasons, they have a hard enough job showing that they've got new drugs that actually work and can be approved by the FDA. But eventually, we do have an opportunity in most circumstances to circle back and take a look at different formulations, like liquid formulations of drugs, or administering a pill drug in an oral solution that can be easier to swallow. So a drug like Sorafenib, for example, we've worked out with our pharmacy a protocol for getting the Sorafenib into an oral solution for patients who can't swallow pills. And so we do work that out with our pharmacy, and I think that that's being done for the most part at an institutional level. The other thing that I would say is that a number of the speech and language pathologists can be really wonderful in working with people with cancers above the collarbones that can affect their swallowing, and can work with patients to develop strategies for being able to swallow their pills as well as other foods. So I often will send patients who can't take their medications well and that have to take them in pill form to our really wonderful swallow therapists, and they can come up with a strategy to get those pills in. Was there another question that was other? Yes.
My question is, how do you determine the patient is iodine refractory? You know iodine one taste, but how come they don't repeat it?
So the question is, how do you determine whether somebody has iodine-refractory disease? And again, another really excellent question, and something that I didn't address at all. The definition has multiple factors that are taken into account, but basically, people who have known thyroid cancer that does not take up radioactive iodine are considered to have iodine-refractory disease, as probably the largest example of people with iodine-refractory thyroid cancer. So an example might be somebody who has lung nodules that light up on a PET CT scan. They have a thyroglobulin level that's elevated, and they have a radioactive iodine, either treatment or dose just to do a scan, and then no uptake in those lung nodules on the whole body scan. So that person, by definition, has iodine-refractory disease. Another example of a disease that would be considered iodine-refractory would be people who have thyroid cancer, known deposits. They're given radioactive iodine. It lights up on the whole body scan, but their cancer grows anyway. So if somebody is getting radioactive iodine, it lights up on the whole body scan, but you do a CT scan 3 or 6 months later, and those lesions are growing, even though it's taking up the radioactive iodine isn't working. And so that's considered radioactive iodine refractory disease as well. Okay. So now I'm going to talk about the oral tyrosine kinase inhibitors. So we've had incredible success in the last couple of years with this class of drugs. I'm going to be talking about a couple in particular, Sorafenib and lenvatinib. So let me show you the Sorafenib data. There was a large randomized phase 3 trial that recently came to fruition called the Decision Trial. And this was a landmark study, the first ever randomized phase 3 trial of a tyrosine kinase inhibitor in patients with iodine-refractory differentiated thyroid cancer. And Sorafenib is angiogenesis inhibitor. It also targets several other kinases that can be abnormal in thyroid cancers. So this study was open at multiple centers around the world, and people with iodine-refractory thyroid cancer were randomized to receive Sorafenib or placebo. And the primary endpoint of this study was progression-free survival. Let me just finish the explanation for the study, and then I'll get to your question. So when people on the clinical trial had disease progression, when their cancers grew on whichever drug they were on, then that particular patient was unblinded. And if that person, it turns out, was on placebo, that person then went on to receive Sorafenib. So as a result of that crossover for the patients that were on placebo, what that means is that ultimately almost everybody who was on the trial got Sorafenib. And because of that, it's a great study design, and it means that everybody who goes on the study can get the drug, which would be a good thing if it turns out to work. But what that means is that you can't look at improvement in overall survival as a primary endpoint for the study. Since everybody's going to get the drug, it's really just a matter of, are they going to get it now or are they going to get it later? And so that's why progression-free survival is a primary endpoint of the study. I'm sorry. Well, so how many months was later is the question, and the answer is it would be on an individual patient-by-patient basis. So if a patient had disease progression at 4 months, then we would look and see, I'm sorry, I shouldn't say we since I didn't do the study, but they would look and see, was that particular patient on placebo or Sorafenib. If at 4 months they had progression and that person was on placebo, then they would start getting Sorafenib. The next guy might have progressed at 10 months, and then the investigators would find out if he was on placebo or Sorafenib at 10 months, and if on placebo, then cross over at that time.
What was the criteria? What were the criteria of progression?
So it was the same RESIST criteria that I mentioned earlier, that same definition of an increase of 20% in the sum of the longest diameters of the lesion. Yes, you had a question?
So what was the amount of Sorafenib that was taken by these patients? And in this study, I believe, and I don't know if it's correct, but that some people, the dose was
Right, the question is, what was the dose of sorafenib, and then weren't some people dose reduced? And so the dose was 400 milligrams twice a day for sorafenib, and then, of course, the same dose for the placebo. And you're correct that there were a number of patients that had dose reductions or had to have the therapy discontinued as a result of side effects. And I'm going to show that data in just a sec. So this slide shows the primary endpoint for the study, the survival curves in terms of progression-free survival. So progression-free survival is basically how long do people live without their cancer progressing. And so the red line on the top shows that the people that were on sorafenib first, and the blue line on the bottom shows the curve for people who are on placebo. So what you can see is that the progression-free survival was better with the curve on the top compared to people who were on placebo. So the progression-free survival with sorafenib was 10.8 months and 5.8 months with people on placebo. And also the overall response rate, meaning that the cancer shrunk by 30% or more by using the RECIST criteria, was 12% with sorafenib. There was no overall survival benefit between sorafenib and placebo arms, but that, of course, is confounded by the fact that there was crossover. So it was on the basis of these data that the FDA made the decision to approve sorafenib for the use of iodine-refractory differentiated thyroid cancer last November, almost a year ago. And there's another question. Did you have another question? Okay. So those are basically the data in terms of efficacy of sorafenib. So now what about the side effects? So as I think everyone knows, these drugs cause side effects. One of the more common side effects with sorafenib is hand-foot syndrome. And I'm sorry, I think with the light this might not show very well. Hand-foot syndrome can be a painful rash with very thick calluses or breaks in the fingertips or in the toes that can involve particularly the palms and soles of the feet. It can be quite uncomfortable and quite difficult to manage and really impact on people being able to walk and do things with their hands. Definitely something that we need to contend with. Other rash can be seen as well. This person had a rash across their front and back on sorafenib. Another class effect with these drugs overall is that they cause some GI side effects. Not a lot of nausea and throwing up, but some low-grade nausea, impact on the appetite, and diarrhea. And so that combination of side effects can be a real problem in terms of weight loss. And I have to work very hard with a lot of my patients to not lose too much weight. Everybody's always really happy with the first 10 or 20 pounds that go, but it becomes a real problem. And so I actually have a couple of really wonderful nutritionists who work with almost all of my patients that are on these drugs to really help combat this problem. Fatigue is another side effect that's not negligible with this class of drugs overall. And then high blood pressure is something that we see with this class of drugs and has to be managed very carefully. One of the things about this class of side effects is that these drugs are taken every day, and people often have these side effects every day. So if you're going to be on a drug for, say, 11 months, you might have to contend with side effects like this on a day-by-day basis, week after week, month after month. So lots of questions in the green shirt.
Is there a correlation between having a high blood pressure and the drug actually working? Like if you go on the drug and you have no side effects, does that mean that the drug probably is not working on your cancer versus those that are getting some or all of the side effects and then it's working?
So the question is there a correlation between high blood pressure and the drug working or not? And with sorafenib, I have to admit I don't know the answer to that question. I'm not 100% sure that has been looked at with this in the sorafenib trial. However, that has been looked at in the lenvatinib trial, and there was actually a very strong correlation between the onset of high blood pressure and how well the drug worked, both with progression-free survival and response rates. So there's this phrase in oncology called a pharmacodynamic marker, which we mean thinks that side effect actually predicts the response. So I think what that means to me as a person taking care of people with thyroid cancer is that when I'm using these drugs, if they get high blood pressure, I don't want to just stop the drug because they got high blood pressure. I need to manage the high blood pressure properly and try to keep the patient on the drug, because that's a sign that they may actually be benefiting from the drug.
The other thing is, my husband was on Sorafenib and everolimus in Dr. Sherman's clinical trial with Foll. He had many of those symptoms, but mostly in the first month, and a lot of them went away.
Yeah, so the point is that the commentator's husband is on Sorafenib and everolimus on a clinical trial out of Memorial Sloan Kettering, and he had many of these side effects that are shown up here on the slide, but many went away over time. And yes, that can happen where many of the side effects can eventually go away over time, and also we manage them better over time, and I think patients themselves learn how to manage them themselves over time, learn how to take care of their skin and their feet and deal with the diarrhea, make changes in their diet and so on and so forth. But many of these side effects do just get better over time. That is true. Let me get the white shirt gentleman. And
The hand and foot skin reaction, is that due to rapid cell death and regeneration? Is that what causes that?
so the question is does rapid cell death and regeneration cause the hand-foot syndrome? And I think the answer, is probably not, but we actually don't really understand exactly what changes in the signaling of the cells in the epidermis are responsible for the hand-foot syndrome. But I think it has more to do with the cellular targets that are inhibited by Sorafenib that cause that as a side effect. Okay.
Can you comment about the incidence?
Let me see if I have, I'm sorry, I don't have a slide that shows the exact incidence of these side effects on the decision trial. And not being an investigator of the study myself, I don't remember exactly what the numbers were off the top of my head. But in terms of hand-foot syndrome, diarrhea, weight loss, those incidences in general were more than 50% of patients that were, and rash, more than 50% of patients on the study, if I'm not mistaken. However, these symptoms and side effects are also graded, and we grade them 1 through 5 basically, and grade 1 and 2 side effects like this in general can be quite mild and for many patients easy to deal with, whereas in general grade 3 and grade 4 are more difficult and require some sort of adjustment in the approach to attenuate those side effects. So I'm sorry I don't have great numbers on those to really accurately represent it. Okay, Kathy.
If you've already got a patient that's already hypertensive, and this is another added side effect, would you necessarily have to increase their dosage?
Yeah, so just to rephrase the question, what do we do when people already have high blood pressure when we're thinking of starting them on these therapies? So we do want to make sure that people who are already who already have high blood pressure are appropriately treated for their high blood pressure. We want to have their blood pressure be appropriately controlled before starting Sorafenib with therapy, and that is the case with most people who have already been treated for high blood pressure. And then for those people, we keep a close eye on it, but we keep a close eye on the blood pressure of all of the patients who are starting on these drugs, and then make adjustments in their medications. Many people who already have hypertension need to have an increase of their antihypertensive medications, or if they're already maxed out on one drug, we need to add in a second drug. On occasion, I've even had to add in a third drug in order to manage somebody's high blood pressure. And if you've maxed out on antihypertensive therapy, then we need to dose reduce the Sorafenib or Lenvatinib, because people can't just walk around with high blood pressure without it being adequately controlled. One fine point about that, but not always a minor one, is that the high blood pressure related to these drugs goes away very quickly when the drugs are stopped. So if somebody is, say, sick, they get pneumonia, they're admitted to the hospital, we might hold the sorafenib or lenvatinib in that situation, and then continue all of their other regular medicines, including the 3 blood pressure medicines that they got started on. Many people will suddenly end up with very low blood pressure when they're off of these drugs, and so we have to stay on top of it even after you stop the drugs or hold the drugs temporarily. Yes?
Two-part question. Do you have statistics for Sutent versus this one? And also, how high does the blood pressure need to go before you really start to worry?
So the first question is, do we have data on sunitinib compared to sorafenib in differentiated thyroid carcinoma? And no, unfortunately, we don't have any comparator data at all between one TKI and another TKI. There haven't been any clinical trials that have compared, that have pitted one TKI against another TKI in a randomized phase 3 fashion. And that's really the gold standard for us to really know truly, is one drug better, more effective than the other drug? And so I don't think we have the answer to the question of what is the most effective TKI. So we need to look at these other studies that don't compare one to the other to know what's best.
For Sutent, are the statistics pretty much the same as for this one? If you look just at Sutent.
Yeah, so the question is do we have the same kind of data for Sutent that we have for sorafenib? The clinical trials that have been done with sunitinib are smaller than the decision trial that enrolled more than 400 patients with iodine-refractory thyroid cancer and had a placebo comparator arm. The studies that have looked at sunitinib are much smaller studies that have not had a placebo comparator arm in a randomized phase 3 fashion. So that level of data in terms of what we think about the not the quality of the data, but sort of the biostatistical significance of the data isn't quite as good when it's a smaller number of patients in a non-randomized single-arm study compared to a randomized phase 3 trial. Did I get all of your questions? Oh, the blood. Yeah. So when do we start to worry about blood pressure? We will act on blood pressure when it's elevated by standard criteria, but when we start to worry about it is if the blood pressure is greater, if the upper number of the systolic blood pressure is greater than 160, or the bottom number or the diastolic blood pressure is greater than 90. So we have patients monitor their blood pressure at home, and if they have a blood pressure, if either one of those numbers is higher than 160 or 90, then we have them call us, and then we take further action. But we also have people monitor their blood pressure at home, keep a log, and if it's consistently 140, 145, over 85, 87, then we'll usually start a blood pressure medicine on that basis as well. Did you have a question? No? Okay. Okay. Let me do the white shirt, and then I'll get the brown jacket.
Could you ever explain how sorafenib works? What does it do to the thyroid cancer?
So the question is what is the mechanism of action of sorafenib? How does it work? Sorafenib hits several different abnormalities that are frequently found in cancer cells in general. One of the things that it does is it targets VEGF-R, or one of the angiogenesis receptors in cancer cells. It also has some activity against RAF, which is one of the things that is abnormal in many thyroid cancers. That was the original reason that there was some interest in studying sorafenib in thyroid cancer, but it turns out that it doesn't look like the activity correlates with the mutations in RAF or BRAF in thyroid cancer, and so we think that it probably is more the angiogenesis inhibition of sorafenib that is responsible for the activity. But it's actually been a little bit difficult to figure that out, and we don't really know for sure. The gentleman here in the brown jacket.
My question was basically answered. Has there been any statistical studies or effectiveness vis-a-vis particular mutation
So another great question. The question is have we looked at the correlation between the various mutations that we know are present in thyroid cancer and the activity of these drugs? And that has been investigated with Sorafenib as well as some of the other drugs. And in general, it does not seem to be that a particular mutation, such as the most common one, which is in BRAF or a RAS mutation, predicts responsiveness to Sorafenib or to lenvatinib. So we don't pick people out based on their genotype and start them on these drugs because it doesn't really seem to matter. People do seem to have benefit regardless of their mutational status. Okay, so I'm going to move along. One of the other things on the slide that does that I think was related to one of the questions that I will mention is the frequency of dose reductions and then even having to stop Sorafenib for some people because of side effects of the drug. And this is not infrequent. 64% of patients on the decision trial did have to have dose holds or dose reductions in order for them to be able to tolerate the drug. And then 19% of patients did have a discontinuation of Sorafenib because of side effects. And so I think, what that means to me is that these drugs need to be given by providers who are familiar with the drugs and who really can help manage the side effects appropriately on the therapy. So now I've mentioned lenvatinib a number of times. Lenvatinib I think is worth mentioning because we recently completed another very large randomized phase 3 trial. So I'll show you the data. I grew up in the 1980s, so I can't help but calling lenvatinib the new kid on the block, although I know it's corny and really shows that I have no good taste in music. But it's true. But lenvatinib is similar to Sorafenib. It's in the same class of drugs in that it's an angiogenesis tyrosine kinase inhibitor. It also targets several other kinases, including the FGFR receptors, which are frequently misregulated in multiple cancers, including in thyroid cancer. And the fact that lenvatinib targets the FGFR is one of the more unique features of lenvatinib, particularly compared to Sorafenib, which does not target FGFR. So it was basically on the basis of this profile that lenvatinib was studied in iodine-refractory differentiated thyroid carcinoma as well. So this slide shows the design of the SELECT trial that was recently presented at ASCO, the American Society of Clinical Oncology, just this past June. And just the other day, the paper was accepted for publication in the New England Journal of Medicine. So that's very exciting, and that will be coming out in the New England Journal of Medicine in several months. But the design of this study is very similar to the design of the DECISION trial, where patients with progressive iodine-refractory differentiated thyroid carcinoma were randomized to receive lenvatinib or placebo. One of the differences in the lenvatinib trial was that patients were allowed to have one prior tyrosine kinase inhibitor. So patients could have had Sorafenib or another drug like sunitinib or pazopanib and still be eligible to go on to this study if their cancer had gotten worse on that prior TKI therapy. So patients went on to lenvatinib or placebo. Of course, we didn't know which one they got. When they had disease progression, they were unblinded, and those patients that were on placebo then went on to receive lenvatinib. So again, the primary endpoint of this study was progression-free survival, just like with the DECISION trial. And then that crossover will, of course, confound the evaluation of overall survival. So let me show you those data. As you can see here, there's actually quite a wide separation in the curves with progression-free survival, with the dark blue curve on top showing how well people did on lenvatinib compared to that curve on the bottom that showed that people that were on placebo had a worse progression-free survival. So the median progression-free survival of patients on lenvatinib was 18 months compared to 4 months for patients that were on placebo. So this was a big difference in progression-free survival that we saw. And another thing that was really exciting about lenvatinib was that we actually saw a really good overall response rate. We saw an overall response rate of 65%. So 65% of patients who got lenvatinib on the study had their disease shrink up by 30% or more by those RECIST criteria measurements on the trial. And so like in the decision trial, there was no statistically significant difference in overall survival between the placebo arm and lenvatinib. I don't show these curves here, but there is a slight separation of the curves as well. So we may see over time that turns out to be statistically significant. We don't know yet. But again, it was on the basis of these data that have now been presented that the FDA has granted lenvatinib priority review, and that was just announced a couple of days ago. Yes?
What's the longest that somebody is continuing to be on the lenvatinib for this week?
So, yes, I do know the answer to the question, which is what's the longest time that somebody has been on lenvatinib in this trial? And the answer is we don't know yet, because patients who were started on the study are still on the study. As a matter of fact, more than 50% of the patients who were started on lenvatinib are still on lenvatinib. I'm sorry, I don't know off the top of my head exactly how long how long ago the study was activated. But there have been patients that have been on lenvatinib on the study for well over 2 years. Yes. Right. Have you reset the clock? So the question is when if somebody's had a nice response rate and the tumor has shrunk up nicely on lenvatinib, what happens when the lenvatinib is stopped? Will the cancer suddenly start to grow really fast? Or do you sort of retain benefit for a long period of time? And I think from a data point of view, we actually really don't know that question. There have been reports of people whose cancers, once they've stopped a drug like lenvatinib, have started growing really quickly, making everyone very nervous that something has changed, and that once the drug gets stopped, then things get bad in a scary way. But it's really hard to know, is that just because we remember those particularly bad cases more, do they get burnished in our minds more than the people who actually do quite well once the drug is stopped? And we have to really do particular clinical trials to answer that question. I mean, we don't have that data now. Hopefully there will be good follow-up of people from this study and other studies, so that we'll be able to get at that question better over time. I think I'll just leave it at that. Okay. Now, what about the side effects of lenvatinib? It's in the same class of drugs as sorafenib, so the list of side effects is really pretty similar. And I think overall the magnitude of the side effects might be pretty similar. But there's a slightly different flavor with lenvatinib compared to sorafenib. For example, the incidence of hypertension was greater in the lenvatinib study compared to the sorafenib study. However, on the flip side of the coin, there was less hand-foot syndrome overall with lenvatinib in the SELECT trial compared to what was seen in the DECISION trial. And then side effects like diarrhea, poor appetite, weight loss, fatigue were in relatively the similar range, to the extent that you can even really compare results from one trial to another trial. Similar to in the DECISION trial, 68% of patients on lenvatinib did have to have some dose reduction or dose modification on the study, and also this is in a similar range to the DECISION trial. 14% of patients on the lenvatinib trial had discontinuation due to side effects. So again, it's certainly not a free ride for all, but it's really exciting in the field is that we really have 2 new treatment options available for our patients, really in just within within a year's time, and it really is a whole new world out there for iodine-refractory differentiated thyroid carcinoma, and the amount of the kind of progress that we've all been able to make over the last couple of years really is phenomenal, and it's a real success story in oncology that we don't get to see too often. And while I'm thinking about it, we all do this together. People who volunteer on clinical trials, like the gentleman who's on the Sorafenib and everolimus study, are making a huge contribution to the field by participating in clinical trials. And so those people who are volunteers are really an important part of this progress, and we definitely couldn't do it without our patients on these studies. So what do we do next? Should we just stop here, or should we keep on going? Do we need even better drugs? And I think the answer is, of course, we need better drugs, and we really have made a lot of progress so far. But we definitely can't stop until we're curing almost everybody with thyroid cancer, if not everyone with thyroid cancer. So what do we do when people have progressed on a VEGFR TKI? Do we put them on another VEGFR TKI, or are they not going to respond because these drugs are within the same class of drugs? As I mentioned in the lenvatinib study, there were people on the lenvatinib study who had received a prior VEGFR TKI, including sorafenib. And I didn't show the data, but those patients actually also had a significant progression-free survival benefit and also had a very good response rate. So we know that you can use lenvatinib after one prior VEGFR TKI and still have benefit. But we're also now doing another clinical trial, taking a look at this very specific patient population. So this study that is shown up here is a study that's being run by ITOG. This is ITOG's first clinical trial ever, and it is still underway. Manisha Shah at Ohio State University is the principal investigator of the study. And anybody who's interested in the study, let me know. I'd be happy to share more. And if we need to be in touch by email, I'd be happy to do that. But this study is taking a look at a drug called cabozantinib, which is another similar VEGFR multikinase inhibitor for people who've had one or two prior VEGFR tyrosine kinase inhibitors with iodine-refractory disease and have progressed on that prior therapy. There's a single arm to the study. There's no placebo. We're giving everyone on the study cabozantinib and then following them and taking a look at the response rate to cabozantinib on the study. So the study is well underway. We now have 18 of 25 patients enrolled, so we only need 7 more patients. So if anybody knows of anybody, a friend or family member who might be interested, please do be in touch. The study is open at Ohio State as well as Mass General in Boston, the Mayo Clinic in Florida, as well as in Minnesota, MD Anderson in Houston, the University of Chicago, and Roswell Park. So now getting beyond the angiogenesis inhibitors in iodine-refractory differentiated thyroid cancer, the question was already asked about specific mutations. So are there genetic mutations that are driver mutations in this thyroid cancer that we can target with the new therapies that are being developed in oncology? And the answer is definitely yes. So this schema here shows the most common genes that are mutated in thyroid cancer. Those are in either the BRAF gene or else in the RAS genes. And so BRAF is seen in about 50% of papillary thyroid cancers, and then mutations in the RAS oncogene are seen in follicular thyroid cancers and also in some papillary thyroid cancers. And just those 2 genes alone account for a majority of the mutations that are seen in thyroid cancer. And those genes signal through this signal transduction cascade through RAS, RAF, and MAP kinase or MEK to basically promote signaling into the nucleus of the cancer cells to tell the cells to multiply and grow and divide. So these mutations are critical in the development of thyroid cancer. And there are now drugs that are being developed that target those specific mutations. Okay, so a couple of questions. Let me get the person all the way in the back. So the question is, when do people get tested for having their cancers with these mutations? I think that it's fair to say that that's really a field that's very much in evolution right now. I saw a table out there for Afirma, which is a genetic testing that's available for thyroid nodules even before a cancer diagnosis to predict, is that thyroid nodule going to be a cancer nodule or not? And that's just one example of just one of the brand new ways that we're using genetic testing in thyroid neoplasia to begin with. So there isn't really any one set standard of care or set of guidelines like with the ATA guidelines or the NCCN guidelines that have made recommendations on exactly what type of genetic testing should be done for thyroid cancer and when. Genetic testing is being done. It's being done probably for a relatively small number of patients right now at somewhat select institutions. What my own personal approach is that for patients who are in my clinic, almost all of the patients that I see will have advanced thyroid cancer that isn't going to be treated with surgery and radioactive iodine. And we are always exploring all of the treatment options available, including clinical trials. And we have a genetic testing system within our own pathology department that's available for all of our patients at Mass General with advanced cancers. And so I genotype the vast majority of my patients who have thyroid cancer. If somebody is not going to be eligible for any drug therapy, I don't do it simply because I'm curious as a rule of thumb. I want to be able to do something about those results if I get them. Otherwise, it's not worth the cost of doing that testing. Yes, another question.
I was wondering, why would you do gene testing?
So the question is, why is gene testing useful? Right now we don't have any standard therapeutic approaches for a BRAF mutant papillary thyroid carcinoma compared to a papillary thyroid carcinoma that doesn't harbor a BRAF mutation. However, we have clinical trials that are taking a look at new drugs that target those genetic mutations. And so in general, I think that's the reason to do the genetic testing right now, so that we can identify people who are appropriate to put into genotype-driven clinical trials, so that we can figure out, are these drugs of benefit in these cancers? Okay, the woman in the green shirt, and then I'll get Kathy.
Is RAS the same as NRAS?
Yeah, so NRAS and HRAS are both two of the RAS oncogenes that can be mutated in thyroid cancer. There are slightly different flavors of the two, but in general, here applies to both.
So I was thinking in answer to my neighbor here, there was an article recently about an exceptional responder who had anaplastic thyroid cancer and responded incredibly well to everolimus, but she had an mTOR mutation.
Right, that's correct, yes.
And 4 years of undetectable, which is fantastic.
Right, so the comment is that there was just a report in the New England Journal of Medicine about a woman with anaplastic thyroid carcinoma who went on a clinical trial, had an extraordinary response to the drug everolimus that inhibits mTOR, and that patient had it turns out that they did testing because they wanted to know, why did that one particular patient do so well, and it turns out that they had a genetic aberration in that signal transduction pathway that everolimus blocks, and that certainly is the likely explanation about why that one particular patient did so well. So that's the state of the art right now. We're just really we're just beginning to learn about how to deal with all of the different genetic mutations in the various different types of thyroid cancers. But that's the reason that we do it, so that we can figure it out. Okay, you had a question here.
Yeah, so it goes back to the angiogenesis. Is there any method to try cocktails of that, since this is slightly different?
So the question is there an effort to look at combinations or cocktails of angiogenesis inhibitors with other drugs? And combinations amongst themselves. So I think that I'm not aware of any effort to look at combinations of one angiogenesis inhibitor with another angiogenesis inhibitor, a TKI particularly, in general, because of the difficulty one might anticipate with the side effect profile. What we try to do traditionally in oncology is mix and match drugs that don't have a lot of overlap in the toxicity profile, so that, because I think it would be very, taking care of people on lenvatinib, for example, I'd have a really hard time adding sorafenib in because the lenvatinib side effects are too similar to the sorafenib side effects, and the lenvatinib side effects are bad enough as they are. So what we try to do in general is come up with complementary cocktails that are complementary, perhaps both in the side effect profile as well as the mechanisms of how the drugs work. And, is there some reason to think that the combination is going to work better than the single drugs by themselves? So there's a small effort that's being done to date. There isn't any large phase 3 randomized trial that's going to be practice changing that I'm aware of, but there are small studies that are being done, including the sorafenib and everolimus study and another study that I'll show you here, taking a look at combinations of drugs. Okay, one last question.
My question's already answered.
Oh, good, okay. So now there are drugs that target BRAF. So you guys may have heard about vemurafenib. Vemurafenib made a big splash a couple of years ago when it was studied in melanoma, because many melanomas harbor BRAF mutations. In fact, the same BRAF mutation that's most common in papillary thyroid carcinoma. The clinical trial that was done with vemurafenib showed that it was a wild success in melanoma. So those of us taking care of people with papillary thyroid cancer were chomping at the bit for a long time to get our hands on vemurafenib and be able to study it in people with lodine-Refractory papillary thyroid cancer that has a BRAF mutation. And we've finally now gotten those studies underway. So this shows a vemurafenib study that was done in a small number of patients at several different centers. This study is now complete. It took a look at single-agent vemurafenib in people who had progressive lodine-Refractory papillary thyroid cancer that had a BRAF mutation. And what we found was that those patients can respond to vemurafenib. For people who had never had a VEGFR tyrosine kinase inhibitor, there was a response rate of 35% that was seen. And for people that had had one prior VEGFR TKI, such as sorafenib, the response rate was 29%. So it looks like there's a signal here that this strategy probably has some legs for this particular patient population. So now I think we're now trying to figure out how do we maximize this benefit, and we're looking at the new generation of BRAF inhibitors. So just like in melanoma, there are several different BRAF and MEK inhibitors that are in development. One BRAF inhibitor is dabrafenib, and dabrafenib has been paired with a drug called trametinib, which targets MEK. And so, but the combination of the two can target two different abnormalities in cells within the same pathway. So you can target, the combination targets BRAF as well as MEK. And so can you get better activity by doing that vertical inhibition rather than just targeting BRAF by itself? And so this study is now underway, comparing dabrafenib as a single agent to the combination of the two drugs, and the primary endpoint of this study will be response rate. This is a study that's sponsored by the NCCN and is open at multiple sites within the U.S., so it's available now for patients to go on this study. The other thing that's really cool, and this is the last trial that I'm going to talk about, I promise, is the idea of targeting this RAS-RAF MAP kinase pathway to try to take advantage of one of the unique features of thyroid cancer, which is that thyroid cancers can sometimes be treated with radioactive iodine. And what many people, including the group at Memorial Sloan Kettering, have shown is that those abnormalities in thyroid cancer cells in that pathway tend to correlate with a loss of responsiveness to radioactive iodine. So can you use these new drugs that target the abnormalities in that pathway to trick the thyroid cancer cells into taking up radioactive iodine? And if you can do that, wouldn't that be nice? Because, radioactive iodine is no walk in the park. I understand that. But I think in general, it's easier for people to get a treatment of radioactive iodine and then go on with their lives rather than to be on lenvatinib, sorafenib, sunitinib, et cetera, on a daily basis. So the group at Memorial Sloan Kettering did a very nice study that was published in the New England Journal of Medicine last year, showing that this drug, selumetinib, can actually enhance uptake of radioactive iodine in some patients with advanced thyroid cancer. And so these figures here show one patient that did have some uptake of radioactive iodine prior to getting selumetinib, but then they were given selumetinib for about a month, and then they had another radioactive iodine scan, and you can see here that there's much more uptake. So this patient got treated after being on selumetinib with radioactive iodine. And so they showed this very nice proof of principle that if you block that pathway, you can at least see some greater uptake in some patients of radioactive iodine. Yes?
I thought they closed that study because it didn't work.
No, that study, which, as I mentioned, was published in the New England Journal, did show that in a subset of patients that were treated, there was activity. So there are two studies that study just finished, and that's why that study is no longer open. There is, however, one study that is now underway that's an international randomized phase 3 study of selumetinib in people with thyroid cancer that have had resection of their thyroid cancer, have no known disease, but are at high risk for recurrence despite getting radioactive iodine. That's called the ASTRA study, and the ASTRA study randomizes people to selumetinib or placebo, and then everybody goes on and gets the radioactive iodine that they were going to get anyway. And the endpoint of that study is to see 2 years or a year and a half down the road if the people who got the selumetinib are less likely to have their thyroid cancer come back. So the study that was done at Memorial finished and then led to the opening of this subsequent large randomized phase 3 trial that will hopefully answer that important question. Yeah.
Because they were not on the study.
So the question is, have I talked to people at Memorial and they were not hot on the study? So just in full disclosure, I've worked very closely with the investigators at Memorial who've done the selumetinib work, particularly on the ITOG study that I mentioned here, I'm not quite sure. I think there's probably something that might be lost in translation. I think that we as a field feel that there is certainly promise in targeting the RAS-RAF-MAP kinase pathway to enhance the uptake of radioactive iodine. The big question is in the long term, is this going to really work, and is it going to have treatment effect? So I'm going to have to wrap things up in just a couple of minutes, as you kindly pointed out to me, so I can catch my plane. But I do want to mention this study, which will be opening probably in early 2015 through the International Thyroid Oncology Group, that's taking a look at selumetinib in people with iodine-refractory disease, but who have a little bit of uptake in their established thyroid cancers, but still are not responding to that radioactive iodine. So we're going to be giving those patients selumetinib or placebo to see if we can improve the treatment efficacy of the combination of selumetinib and radioactive iodine. So coming to an ITOG center near you soon. So I'm going to have to wrap it up. I can take, hopefully I can do all of your last questions. Yep, I've got 4 more minutes to answer any questions that are there, so hit me up.
So on this study, did the patients have previous TKIs?
On the selumetinib study, people are allowed to have prior TKIs as far as I recall.
It's not a requirement.
It's not a requirement, no. Yes?
So the selumetinib, what are the the side effects? Are they like the other ones which were pretty severe?
So the question is does selumetinib have side effects like the other ones that I mentioned? And yes, of course, there's not a free ride with selumetinib either, unfortunately. One of the more common troublesome side effects is a rash with selumetinib that can be pretty significant and can be an acneiform rash, a lot like acne. We don't see the hand-foot syndrome so much, but in acne, nobody wants to have a really bad acne rash, and it can be uncomfortable. The nice thing about this approach is that the treatment on the TKI is just limited to a month or a month and a half prior to getting the radioactive iodine. So rather than starting somebody on a drug and just planning that they're going to stay on the drug until their cancer is growing and getting worse or until they can't tolerate the drug any longer, the treatment paradigm is for a fixed 2-month period of time, basically, and hopefully there will be benefit and you can go on and then not have to do anything for a long period of time. So side effects for a shorter period of time hopefully won't have the same impact on quality of life as if you have to be on the drug day in and day out. And so what I hope that we're coming to is a new hopefully if this idea of radioactive iodine resensitization pans out with drugs like selumetinib or the BRAF inhibitors as well, hopefully we'll be able to help a subset of patients with this kind of intensive combination therapy, but have therapy that they don't have to be on for a long period of time. And if that's the case, it might make more sense to treat more patients who don't have that really terrible disease with a large burden of disease that's growing rapidly, but maybe we can use this strategy for people who have a small amount of disease, who can take 2 months of their lives to have this more intensive treatment, have benefit hopefully, and then go on and get back to their busy lives. Yes?
Do you know anything about the cost of this particular study?
Yes, I do. Do I know anything about the cost of the study? So carrying out clinical trials like this is tremendously expensive. So we in ITOG take advantage of wonderful philanthropic support that we have from donors, as well as we work with industry to help cover the costs of these clinical trials. For the individual patients on the trials, on clinical trials like this in general, the therapies that are being investigated are provided by the clinical trial, and so patients are not charged for the costs of the drugs. But when there are things that are done for clinical trials that are part of the standard of care that the patient would be having anyway, like regular doctor's visits, CT scans, and regular blood tests that would be done as a normal part of care, those things in general will still be billed to people's insurances. So I'm going to take one last question, and then I want to show one last slide, and then I'm going to hit the road. Go ahead.
When do you see FDA approval for that?
Well, I don't have a crystal ball in that, but the like I said, lenvatinib was granted priority review by the FDA. 2014 is almost over, but 2015 is right around the block. Now, I do want to show one last slide and make one last comment, and so I do have to mention Rick Abrams. I'm sorry, a little bit broken up here. Last year when I was here with Rick. Rick passed away a couple of months ago, and he was a member of ThyCa, who I don't know if any of you had the pleasure of getting to know Rick, but I'm sorry. But he just was a totally cool guy, really wonderful, had an incredible amount of energy and zest for life. I worked with him closely on ITOG as well as coming to ThyCa with him. He was a dear patient of mine and a dear friend, and he passed away. I wanted to mention him, and I have to tell a story. He's just such a cool guy. Last year at ThyCa, he came with his Tai Chi guru. And I saw Rick here, and I knew he was going to try to get me to go to the Tai Chi thing with him. And I'm shy, and I really didn't want to do it. And of course, you can't say no to a guy like Rick. So I went to the Tai Chi session with Rick, and Rami, his Tai Chi instructor, probably can rival Rick in terms of his overall, the force of his personality, and had the whole room doing Tai Chi and really getting into it, including the reluctant doctor amongst the group. And it was just one of many wonderful experiences that I had with Rick over the years and getting to know him. So I did want to remember him today. So thank you.